In this lecture, I'll be discussing the dilemma of simple bone cyst in children. This is a common problem that every orthopedic surgeon will encounter during his practice. But before going into the details of this dilemma, I'll state some facts that will lay the foundation to our discussion. First of all, a simple bone cyst is often called a unicameral bone cyst. Unicameral means a single room, or it's formed of one loculus. That's why we call it unicameral bone cyst. Simple bone cyst actually accounts for 3% of bone tumors. 90% of them occur in the first 2 decades of life. The mean age is around 10 years, and it's more common in males than females, the ratio of 2:1. Most of the cases of these cysts usually present following an incidental trauma that directs the attention to its presence. We have to always remember that these are asymptomatic until they reach a large size or they continuously fracture. This is where the problem comes. But you have to remember that they are asymptomatic lesions. They also could present for the first time with a pathological fracture. 80% of these cysts occur in the proximal humerus and the proximal femur. However, any bone in the body could be affected. And in adults, 50% of them usually occurs in the ilium or calcaneus. The etiology is unknown. There are lots of theories. However, the most favorable theory is venous obstruction leading to increased intralesional pressure and accordingly increase in prostaglandins and interleukins. So now where is the dilemma? The dilemma is in the following 11 questions. First of all, how do we diagnose it? Is it really a simple bone cyst or it could be something else? Do we need to take a biopsy? If it is fractured, should I treat it conservatively or operatively? Will it heal or are there cases of non-union? If it is not fractured, do I need to curette it? Do I need to graft it? Do I need to fix it? Do I need to inject it? And if so, with what? Could it recur after treatment? Does it disappear in adulthood? Could it ever turn malignant? All these questions come to mind whenever a doctor encounters this situation. Oh, yal al-hawl. So simple bone cysts actually are not that simple. In the following few minutes, I'll be covering all these details, trying to answer the following questions from my personal experience. So how do we diagnose a simple bone cyst? The most common differential diagnosis is aneurysmal bone cyst and cystic fibrous dysplasia. This is where the dilemma of diagnosis comes, and I'll try to elucidate the differences between these 3 lesions. However, other differential diagnosis includes intraosseous ganglion, intraosseous lipomas, and even some malignant tumors like telangiectatic osteosarcoma. So this is a simple bone cyst, and you can see that it's metaphyseal, purely lytic, and it's central in the metaphysis of the bone. Whereas if you compare it to aneurysmal bone cyst, which have 2 presentations, either central type, the ABC actually balloons the bone, making its transverse diameter actually more than the longitudinal diameter. And you can see if you do an MRI, multiple fluid-filled spaces. The other presentation of an aneurysmal bone cyst when it comes eccentric, and here it's completely different than a simple bone cyst. You can, as you see, the ABC here is eccentric, taking just one part of the bone, whereas simple bone cysts are always central lesions. Cystic fibrous dysplasias are also purely lytic and cystic, but if you look at the walls, you'll find that the walls are sclerotic. You can see here that it has a sclerotic rend like this, and this makes it a fibrous lesion with cystic areas inside. There is no much importance to differentiate actually simple bone cysts from cystic fibrous dysplasias because we treat them more or less the same. And mostly they are both asymptomatic, but this is just to differentiate between both in X-rays. So UBCs are located in the metaphyses. They could extend into the diaphyses, and as the child grows, actually they move away from the epiphysis. They're always central. The length is always more than the width, and it has its greatest transverse diameter closest to the epiphyseal plate. And even when they expand the bone, they expand it in a uniform manner. Sometimes you hear the word active cysts. Active cysts is actually only a radiologic finding when the cysts are adjacent to the physeal plate, but they are not more aggressive, and the incidence of recurrence following treatment is the same whether they're active or latent. So it's just a term, a radiological term, that means that the cyst is adjacent to the physeal plate. The cysts are always plurilytic in the X-ray, and even if you find that there are trabeculae inside, these could be following fractures, but mostly it's formed of one loculus. The walls are eggshell, but they're always intact and they heal after fracture. There is what we call sometimes following fracture a fallen leaf sign. It is a diagnostic sign. It means that a part of the cortex following fracture trickles down the cyst and lays in the bottom of the cyst. And this happens only if the cyst is formed of one loculus, whereas if it's multilocular, this part of the bone will not trickle down to the bottom. You never find soft tissue extent following with an unicameral bone cyst. Never penetrates the cortex. You can see here an example of the unicameral bone cyst of the proximal humerus, and you can see here this part of the bone that fell to the bottom of the lesion. This is what we call a fallen leaf sign. If you see the MRI, it's formed of just one loculus. Another example in the proximal femur, you can see that it is expanding actually the neck of the femur, but it's a uniform expansion, purely lytic and metaphyseal in location. Another example of a simple bone cyst of the proximal femur. You can see here following fracture of the femoral neck. This is a diaphyseal cyst, also a simple bone cyst that moves away from the epiphysis, and you can see here also the fallen leaf sign. Another example of simple bone cyst in the metaphysis of the distal fibula. And although in the X-ray you find these trabeculae, but still it's a one loculus cyst in the MRI. Simple bone cyst of the distal femur, proximal tibia, and in the calcaneus, purely lytic. So, do we need to take a biopsy? Actually, no. These are easily diagnosed with an X-ray, and only if you are in doubt or it's not a classical unicameral bone cyst, then you need to have a tissue diagnosis. A biopsy would never hurt, but in most of the situations where you encounter a unicameral bone cyst, you can easily diagnose it, as we've seen, with an X-ray, and maybe with an MRI could be of help. You always have to remember the clinical and radiological findings. So now, if you are encountered with a unicameral bone cyst that has fractured, which is very common, parents come with their child following a minor trauma, and you see that he has a pathological fracture due to a unicameral bone cyst. So do you treat it conservatively or operatively? Actually, most of the cases in the humerus, we treat them conservatively. They heal within 4 to 6 weeks, and they're completely solid. We never encountered non-unions or delayed unions, so long that there are no manipulations or operative interventions have happened. So they heal very nicely, conservatively, and you don't need to do any operative interference in them, so long as they are aligned properly and they'll heal in a timely manner. And you can see here how they heal nicely. So following fracture, they heal completely. And in some cases, actually, the walls become stronger following fracture, but this is not the rule. So some of them actually get stronger following fractures, others remain the same. So do we need to inject these unicameral bone cysts, and how do we inject them? With what material? Actually, we inject cysts that are increasing progressively in size, but this is not the rule. And there are lots of material that you can inject with, either steroids, bone marrow, demineralized bone matrix. There are a lot of literature regarding every material of these, and most of them are more or less similar. However, there are studies that have compared all these materials in injection. One of the biggest trials was done in 2008. It's a clinical trial that involved 24 centers in USA and India, and it's in the Journal of Bone and Joint. And they compared steroids to bone marrow, and they found that steroids had a better outcome than bone marrow. However, they both had a similar clinical outcome. They differed in the radiological outcome, but in the clinical outcome, 70% of these patients didn't require further treatment. And they said that this outcome is more or less similar to curettage and graft. So if injection, which has minimal morbidity, would give the same outcome as curettage and graft, then why do added morbidity? Injection would do the job. And they said that you can inject 2 or 3 times, and it's 3 milligrams per centimeter of cyst volume. Whenever you follow up a simple bone cyst, or whether you're treating it conservatively or following injection or even grafting, your main concern should be the wall of the cyst and not what's inside the cyst. So we comment all, or we're happy always when you see that the wall is thicker in the follow-up, because this is what will prevent the fracture. We don't care much about what's inside the bone. So if you're following up this cyst and you find that the walls got thicker, but the cyst is still present, this is not a recurrence, and this doesn't warrant any further intervention. So always when you follow up cyst, you just look at the walls. You don't care about what's inside. We don't care if this cyst is there or it remains there forever. All what we care about is that the wall are strong enough to prevent further fractures. This is a case following demineralized bone marrow injection, and you can see that it heals. This is a patient that was treated by steroid injection, and you can see that the walls here became thicker following steroid injection. Do we need to curette the lesions and graft them? I mean, if injection would do the job, then why do we need to curette them? Most orthopedic surgeons, whenever they see a hole in the bone, they're more inclined to fill it with graft or with bone graft substitute or whatever, because they feel more comfortable and they feel that this will make the bone stronger. But actually, in a lot of cases, once you graft them, by time it resorbs and you return back to square one. And there isn't much consensus about whether graft is good in treating unicameral bone cysts or not. But in 2014, Kadim et al. Did a systematic review and meta-analysis, and it was published in the Journal of Children Orthopedics, which is a peer-reviewed journal, very respectable. And he compared the different methods for treating unicameral bone cysts, and found that conservative treatment actually yielded 64% success. Injection was much better, 77%. Just decompressing the cysts with a cannulated screw yield 90% success. Curettage and grafting yielded 90% success. Bone marrow injection and demineralized bone, 98%. And just fixing the cyst with flexible nails had 100% success. These were the results of this systematic review. My personal opinion actually is that grafting is not that successful, especially in young children younger than 10 years. The younger the child, the more incidence of recurrence following grafting. And actually, in our practice in Cairo University, we rarely, if ever, graft curette and graft simple bone cysts. This is an example of a proximal femoral unicameral bone cyst following grafting and recurrence following grafting. The graft actually resorbs with time. And very often we see patients who did iliac crest bone grafting and it failed, and they did from the other side and it failed, and then they took from the mother, then bone graft substitutes. So it's a procedure with morbidity and unpredictable outcome. The next question that comes to mind, do we need to fix the cysts? In the proximal femur, it's mandatory, whereas in the humerus, we rarely need to fix them. In athletes, it's also a very good option because they're exposed to constant trauma. Why do we need to fix them in the proximal femur? Because we can't afford that these lesions fracture, because even if they fracture and heal, they'll cause morbidity, whether malunion, whether non-union, and this area is exposed to a lot of stresses. So we only fix cysts in high-stress areas like the proximal femur and sometimes in the diaphyseal femur, and in athletes with repeated fractures who are exposed to a lot of constant trauma. How do we fix lesions in the proximal femur? Either by flexible nails, like in this case, or using Wagner technique. And cysts in the proximal femur could be tricky, because if you want to fix this proximal femur with the cyst just abutting the physeal plate, you have to have anchorage distal and proximal to the cyst. And so if you're going to use screws like this, you're going to disrupt the physeal plate and cause growth disturbance. So this is not acceptable. And if you're going to put short screws like this, this wouldn't do the job, and eventually it will fracture as well. So what we do is we use this Wagner technique using K-wires that are bent over the femoral diaphyses. These would not affect the physeal plate, and at the same time cause adequate fixation that maintains the integrity of the bone. And there are different examples, and you can use a combination of these wires with the side plates, modified plates, so long as the physis is bypassed with smooth K-wires, it's fine. The following question that comes to mind is, do we have to follow these cysts all through the life of this individual, or once he reaches adulthood, these cysts resolve? Actually, they resolve following maturity. Very rarely we'd find cysts in adults. Usually these are not unicameral bone cysts, but rather cystic fibrous dysplasias. And even if they are present in adults, they're usually present in the iliac bone in the pelvis or in the calcaneus, and they're asymptomatic and never causes any morbidity. Could these cysts ever turn malignant? Actually, never. Only case reports are present in the literature, less than 0.01%. Hence, this doesn't warrant any long-term follow-up. These cysts usually resolve with time, and on the other hand, even if they're persistent, which is very rare, it's very rare that they turn malignant or cause any later morbidity. Finally, this is an algorithm of how we treat unicameral bone cyst. So first, the patient presents with an X-ray of a possible unicameral bone cyst. We take a history. We specifically ask them if they had any complaint prior to this episode of fall or fracture. Most of the patients with unicameral bone cyst would say that they never had any problem. This is the first time that they know that they had something in their bones, and this is very confirmatory of the asymptomatic nature of the unicameral bone cyst. So once you get this history, if you're confident of the diagnosis, Then you check if it's in the upper limb or in the femur. If it's a cyst in the femur, whether it's not fractured or it is fractured, it warrants fixation. And we've mentioned how we fix cysts in the proximal femur. However, if the cyst is in the upper limb, in the proximal humerus or in the leg, if it presented with a fracture, we splint it in the appropriate position for 4 to 6 weeks, and then we follow them up. If it increases in size, we do injection either with steroids or demineralized bone matrix. If it repeatedly fractures in a manner which is annoying to the patient, we do prophylactic fixation. However, if the cysts present without a fracture, we follow them up in the same manner, and if they increase in size, we inject them. If they're repeatedly fractured, we do prophylactic fixation. On the other hand, if from the history we're not confident that this is a unicameral bone cyst, we do an MRI to make sure that it's single locus, no tissues, no soft tissue extension. And if we're in doubt, we confirm this with CT-guided or sonar-guided biopsy. So this is the algorithm that we use in our university. I hope this could be helpful. Things to remember during follow-up. We should never change the quality of life of the child by restricting his activity under the assumption that this would maintain the integrity of the bone. If the bone will fracture with the regular child activity, then you need to make it stronger by intervening. And this situation is encountered with the family a lot. We see a lot of families, once they know that their child has a unicameral bone cyst, they stop him from doing sports. They're very cautious about him, and they affect his psyche. So we don't want patients to just have an intact bone, but a disturbed psyche. If the cyst is going to cause repeated fracture, you should intervene by prophylactic fixation or addressing it in a way. This is not a patient that you'll treat conservatively. The other thing to remember, in follow-up x-rays, it is more important to assess the thickness of the wall rather than obliteration of the cyst. We don't expect that the cyst to be just filled with bone. The marrow is usually doesn't have anything inside. What you follow up is the wall of the cyst and not what's inside the cyst. And lastly, cysts tend to move away from the physeal plate. They might increase in size when you follow them up, but the increase is usually proportionate to the growth of the bone, which is okay. This is not worrisome. We worry only if the cyst increases in size in a transverse diameter or it expands more. I hope we've sorted some of the answers to this dilemma. The questions were, how do we diagnose a simple bone cyst and how we differentiate it from a aneurysmal bone cyst and cystic fibrous dysplasia? We covered this. We should rarely take a biopsy because it's a radiological diagnosis. If it's fractured, it usually heals conservatively and it heals quickly. Rarely, if ever, do we find patients with non-union or delayed union. We rarely need to curette them and graft them, and we need to fix only cysts in the proximal femur or femur, and in the rest of the body, only in athletes do we need to prophylactically fix them. If the cyst increases in size, we'd inject them either with steroids or demineralized bone matrix. If it recurs after treatment, we have to address it again. It does resolve in adults and it never turns malignant. Thank you, and I hope this has been helpful to just elaborate on some of the questions that comes to mind whenever you encounter a unicameral bone cyst.
أتمنى أن يكون الفيديو ده كان مفيد ليكم، وفي انتظار تعليقاتكم وأي كومنتس أو استفسارات، وإن شاء الله أقدر أرد عليها في أقرب فرصة ممكنة. وإلى اللقاء في فيديو آخر إن شاء الله يتعلق بأورام العظام.